sorry, and we are on track to having a discussion later, so hold your questions.
Wonderful. Thank you, and thanks to all of my colleagues for I think, setting the stage here today. It's a pleasure to come and speak with you. My role on the malaria team at the Gates Foundation, I serve as the Deputy Director for Medical Interventions overseeing our diagnostics, drugs, and vaccine portfolio. But I really wanted to, let's see here. Which one is it? Oh, there it goes. But I really wanted to say a special thanks to Sophie Allison, who's been leading this program for our team over the last 3 or 4 years, both for her tremendous technical contributions to help move this field along and a lot of what you heard about in the last hour, but also her leadership thinking forward about where we think the field can go in terms of helping to provide tools to accelerate towards zero. So, Sophie, I just wanted to say up front, thank you for all of your efforts. So I think this was already sort of touched on, but I think organizationally we think about diagnostics really in 2 main use cases. One is symptomatic case management, and the second, which we've talked a lot about in this session, around asymptomatic screening. And I'm going to organize my thoughts along those lines. And I think the first point is we still have work to do around symptomatic case management. It was already pointed out earlier. So again, I think a key point here is that this is a mature market, but I would say it's not still a stable market. I mean, 200 million RDTs a year, and we have lots of questions around case management, some new emerging problems related to resistance in terms of basically immune evasion of the test, whether that's solely from a test and treat approach that we've used with RDTs over the last decade, or whether that's also from the reduction in the multiplicity of infections, where, again, if people, as we heard last night at the McGill Symposium, if people are infected with more than one strain, you might not expect to see HRP2/3 deletions as frequently, because the overall phenotype would still be the presence of HRP2 in the bloodstream. So I think I just wanted to kind of touch base on that, is that we need to be able to sustain and expand quality RDTs for case management. I think we're actually entering a time of some uncertainty for 2 reasons. One is, as Xavier mentioned, is a bit of a transition from the WHO fine testing system that we've had over the last decade now to WHO pre-qualification. And the second one for that is actually going to be coming up over the next couple of years, culminating in 2022 with the end of the current CE mark system and the switch over to CE IVDR, which is going to require more clinical tests for the products to be registered going forward. So I do think we're going to see continued changes in the marketplace around RDTs. And this is an example, or as a framework that was put together by our colleagues from the RDT task force, thinking about what a healthy RDT market looks like. And so one is having an adequate supply of quality-assured diagnostics. And from that, building up to we have, more than a couple of suppliers that can support that. That's a big market, and it doesn't take a lot to have perturbations in our supply and demand. And that's kind of what you see there on number 3, is that your supply can equal demand. But then on top of that, we need to have some degree of buffer capacity and to support ongoing product innovation, as was raised, as I think we kind of got behind that for a while, and I'm excited to see that moving forward again. So I think just recognize that this is not a static field, and there are very active changes and pressures that are going to go on in the next several years in the RDT marketplace. The second point, which was already alluded to a couple of times, is that it doesn't matter whether it's diagnostics or drugs or vaccines or insecticides, we will see the emergence of resistance due to evolutionary forces when you put pressure on a population. If you're trying to eliminate parasites or mosquitoes out of the population, that's what we would expect to see. This is not a new problem with RDTs, as was mentioned earlier. In fact, in South America, it's an extreme problem to the numbers that were discussed earlier. I think what's new is we've seen this now in more widely in Africa, and again, whether it's due to our test and treat strategy over the last decade or a combination of that reduction in the multiplicity of infection remains to be seen. But I think what is very clear is that this is data that was published earlier this year from the Horn of Africa region, is that the RDT negative tests are you know, if the HRP2 is lacking on the surface, not surprisingly, the HRP2 test can't detect it, and so these densities can be quite high and still not be detected. And obviously the WHO has launched and has continued to expand the efforts to try to standardize protocols to evaluate for these parasites. So where are we today on trying to come up with new tests for case management to solve this? Well, you know, what we've had the last couple of years have been a variety of different tests. You could obviously use a pan-LDH test alone, or you could use as sort of pointed out here, the concept of a triple line test where you'd have both an HRP2 line and a PF-LDH line, but you now have a 4-line test, which at least the feedback we've gotten from the community is people aren't 100% sure how to interpret that. They're either used to a 3-line combo test or a 2-line PF-only test. And so one of our goals over the last year was to try to reach out and see, could we create a test that would actually basically have HRP2 and PF-LDH essentially side by side or together, so it would look like a standard PF test, but actually be able to test to detect both HRP2/3 producing and HRP2/3 deletions. And that work is ongoing, and I hope we'll have products in validation testing here in the next year. I think the other issue that was raised by my colleagues is that we've really had ongoing challenges with PV RDTs, and I think that was nicely pointed out. And certainly, as we're now bringing on the first new Vivax radical cure drug in 60 years, in tefenoquine, which was approved earlier this year, and with the G6PD testing, which I'll touch on at the end, we really do need better PV diagnostics, and I think the combination of a good diagnostic with a good G6PD test and a good 8-aminoquinoline that's a single-dose cure, so you don't get these repetitive infections that have traditionally plagued either not using Primaquine at all or using Primaquine but only taking a few days until you feel better. We know we've not been able to really knock down the number of relapses in Vivax. So we really are excited about trying to bring along new PV diagnostics as part of that suite of tests to what I say sort of reimagine radical cure for Vivax. And the good news is this is actually happening. So Jane Cunningham was kind enough to provide some of the data. The Round 8 report will be coming out very shortly, I think perhaps even this next week or so. So you can see here, this is 2013. This is, again, that lower cutoff of 200 parasites per microliter of Vivax in the tests that were done in 2013. And this is what it looks like with the tests that were run this last year at 200 parasites per microliter. So clearly, the tests for Vivax are improving. I would argue they're still really not where we want them to be, but we're headed the right direction. And so one of our challenges that we also put out to industry was to see, you know, could we actually improve on this and actually get to a level of detection of PV-LDH that would ascertain all clinical infections with Vivax. And so again, this product, I'm glad to say, is also approaching validation testing. But in addition to that, because many of the areas where Vivax is common, PF is a less common infection, And that's where we often are seeing these HRP2 deletions. So we've tried to put a combination of a test that'll pick up those HRP deletion PF tests with a PV test. And I think you'll hear more about that hopefully here in the next year or so. And lastly, in terms of thinking about case management, I wanted to at least raise the fact that one other way to get around this, as we said, we don't, is HRP, can we push LDH far enough to get the sensitivity we'd like? That's still an ongoing effort that we'd like to see. But what other targets do we have? FIND had worked with us a couple of years ago to landscape other potential antigens, and we really kind of landed that LDH is where we really needed to push in terms of the limits of detection. But what other targets are there? Well, one of the other interesting ones is hemozoin. I think many of you, there are several presentations on some of this work here, but can you use any of a series of detection technologies to be able to pick up hemozoin in the bloodstream? And while some of the early efforts actually did this on blood, I think one of the areas that we want to explore, and work is already being done, but to try to expand whether this could be a non-invasive, so that at least at densities of parasitemia and presumptively hemozoin that would be present in case management, whether that could actually be sensitive enough and would allow the opportunity for expanded use cases of how you might approach malaria diagnostics. So is this something, for example, that you could test at a pharmacy or so forth and actually get therapy? So I think more work to do on that, and I think some exciting work that's gone on, and hopefully we'll be able to bring this towards actually a product. And I think the last point I just make on case management, again, going back to the McGill Symposium last night, and I think the theme of that was very much focused on how we can improve surveillance and use that as both as a tool for intervention. So whether that intervention is a drug therapy or whether that intervention is any one of approach of products that can reduce malaria transmission. Or to target collection for genotyping. But I think the other piece of this would be is we have technologies now where we're using phones to be able to capture RDT results, but how can we move beyond that to harness that technology to do additional things, not only geolocation, but perhaps to be able to help us more to collect and standardize the data from the RDTs that we have today. So these are some of the things that we're thinking about. And there's a lot of ways to do that, and some of these, the issues of cross-cutting areas that we've been investing in, such as creating those specimen banks that Xavier mentioned, I think are important as we kind of move forward. So we're going back and re-looking use cases and how we might be able to bring forward some of these technologies for case management. And I think the last piece, an area that we've not been involved in, but I think we would love to sit down and talk with those who've been working on this, is to say, okay, as you get towards zero, more and more of your fevers are not malaria. So at what point can we think about integrating diagnostics that we could at least also determine if it's not malaria, is let's say a bacterial infection for which antibiotics would make good sense, and bringing together the communities working on antibiotic stewardship and malaria together in what I would say maybe the next generation of RDTs. So you've heard about already the challenges of quite getting sensitive enough. This is one of Sophie's slides that I always like to think about. The comments around LAMP or more sensitive tests certainly remain an active discussion, especially as you get to low density infections. And I really won't talk too much about this further because we've already had a robust discussion about it, and we can talk about it a bit more. But I think a couple of areas where we do need to still have further investment are specifically around pregnancy, and you've seen some of the data from South America. And again, I think as with all of the RDTs, what we're seeing is that in different epidemiologic settings, the results are slightly different, and we still need to collect the breadth of that data to best understand how an ultrasensitive RDT might help in pregnancy. in meeting with some of the folks from the Malaria Drugs and Pregnancy Consortium over the last couple of days. The big challenge is really first trimester, and it's figuring out if a woman is pregnant when she first comes for that first antenatal visit, and how you might approach a treatment in that setting where the drugs that we have outside of SP, which is not working well everywhere anymore, what are the best options in that setting? So I think there are still a variety of questions around pregnancy that we need to answer. Certainly ongoing work, both with in multiple settings, both in Asia and in Africa, to really understand the questions about how much of those low-density infections transmit. This is data from Burkina and Khalifi from Tunbusima's group. And I think what you can see here is the orange here are these numbers here at the bottom are corrected for mosquito exposure with parasitemias of greater than 200 per microliter. And that you can see that there's an awful lot of infections that can transmit below 200 parasites per microliter. And as we talked about, that's kind of where we're evaluating our tests. So from an elimination perspective, I think a good question is, do we need to push to lower cutoffs, as Xavier talked about in the last session? And lastly, certainly another area of that we clearly do need ongoing work is we think about diagnostics in a cross-sectional perspective all the time. But the reality is infections are a longitudinal process. So how many of the folks who are not symptomatic today when I have the diagnostic test actually are febrile in a week and could be detected then, and then what would be the impact on elimination? Probably not very much. However, most of those longitudinal models that we have today actually come from the malaria therapy studies in syphilis, where people did intermittently get infected. But does that really happen in the real world? That's a pretty artificial setting when you're giving people malaria and intermittently knocking down their parasitemia with drugs. Well, the reality is that we've now got some data coming out of our colleagues at a firm that suggests that that isn't really what we're seeing in Africa, where two cohorts of children, one was given drugs and followed, and this is actually the time until their next fever and next parasitemia. And so they did get a fever, as you can see here, fairly quickly in a high transmission setting within 60 to 90 days. And when these were analyzed clonally, these were new infections. So certainly if you clear an infection, you get reinfected, you get a fever. In the cohort that was not treated, they actually didn't get infected. They didn't get febrile. So again, these are the things I think we've made some assumptions around what's the natural history of longitudinal of infections. And then when those are middle-aged children, 5 to 10, what does it look like in a more immune adult? And how often are these folks getting symptomatic? Where their parasitemias and their gametocytes are waxing and waning, how often are they contributing to that transmission pool? I think are really big questions for which, these new RDTs or LAMP can actually just help us start to ask the right biological questions, not necessarily answer them. And then I'll end my comments just on, because thinking about this a little larger as a point of care, not necessarily a malaria diagnostic, is as I alluded to earlier, it's, I think, also an exciting time to see us move beyond qualitative tests for G6PD testing and actually get point-of-care quantitative tests out in the field. This is an area that we've invested in partnership with PATH and companies have actually invested substantially on their own to try to bring some products forward, because this is a requirement for using tafenoquine. Which is, as I said, is just approved in both the U.S. and Australia this year. The lead product of that, or the lead candidate within this suite of products from SD Biosensor is now approved in several countries and meets our criteria for the TPP as we're moving forward, and we're looking forward to launching this in partnership in advance, and then in partnership for use with primaquine and then tafenoquine as that drug starts to roll out over the next couple of years. We feel strongly at the Gates Foundation we need at least 2 products in this space. and we are looking forward to hopefully having another candidate product come forward that meets our TPP. But this is another area that certainly you'll see, I think, more and more data come out over the next couple of years in the point-of-care malaria space. So I think with that, I'll stop. And again, thank you all for your attention, and I think we'll look forward to answering your questions here at the panel.